This is a podcast where experts in movement and life tackle current concepts in health and wellness and use science and evidence as the foundation of how we discuss each topic. This is not medical advice, but a sedentary lifestyle is much more harmful, so we should move. The Motif Experience, where movement and life come together. I'm your host, Dr. Tyler Cuddy-Ford. On this wide-ranging podcast, we have Dr. Chris P. Bacon, otherwise known as Dr. Meszaros. He, true genius. If you're able to watch, you'll see that he just looks like Einstein. So we're excited to have him. Myriad of topics in motor control and neuroscience, and a true thinker and researcher in physical therapy.
Do you want something from me?
I do have something to share with you, is why I needed to actually...
And you're recording me while you share it?
Yes, so, yeah.
Okay.
Yeah.
And?
Well, we'll get into it later, but it's about your contract. So I'm really not at liberty to say right now until the dean gets here, the executive dean, and then the provost, and then the president wants to say a couple of things too. So
okay.
It's not just me.
Well, I know now that you run in the halls of power, associate dean.
Yeah.
What do you have to do to be associate dean? Do you have to kill somebody or?
I did nothing, and it's like less pay, more work. It's just like, it's horrible.
You have to like knock somebody's kneecaps or?
Oh, no, but there are a couple of kneecaps I'd like to knock.
Okay.
Does that count?
Got it.
So if that counts, then I'm in.
All right.
I did the awkward science on purpose because who we have here today is, Dr. Chris P. Bacon is our guest today. He's anti-social media, anti-people, really, and so
it's true.
It is true. He goes by another name, and you'll figure that out as we kind of talk today.
You can call me Chris.
Yeah. So Crisp is his nickname. That's right.
I don't bookface. I don't Twitter.
No, he does not.
I don't
Snapgram. Yep, Snapgram or Insta.
This is like my public unveiling.
Doesn't even do Insta coffee, so it's got to be long and drawn out. So that's why we.
Thanks for having me.
Yeah, that's why we thought we would have you here, because long and drawn out. So.
Pretty much.
Yeah, pretty much.
I like your studio.
It's our producer JD. She's responsible for all of this. So
I do want to say, like, the two of you.
You did
no. The two, you two have something like it's really special.
Yeah.
And I'm glad for you. And I just don't take it for granted.
Can't.
It's beautiful.
He's done this I don't know how many times, and I still laugh.
It's
so
beautiful.
That's how funny it is. So. Because he does a good job, so.
I mean, you two have history too. Like, your bromance goes back.
Should I tell the story of
which one?
The first time that I encountered you?
Oh, you could do. Okay, you could do that one. Yeah.
You want to do that?
Sure. Yeah.
So, do you know the story, JD?
I don't think so.
No. So, I'm a graduate student at the University of Iowa in the hallowed halls of the Steinler building.
That's right. Old building.
Yeah, old building. I mean, like, the greats have passed through there. Not just like in PT, but I mean, true. Orthopaedics too.
Yeah, right.
So we're in this conference room, and this is a conference room where lives have been chewed up and spit out over the years with journal club articles.
Journal club mostly, yeah.
Dissertation defenses and things like that. So we're in this room, big conference room, and you can sit at the table or you can sit out around the edges.
And I'm the newest.
And you're the
newest member of the.
He's the newest. Like, I've been there a year, so I figured the ropes out, and we're going around. People are going around introducing themselves and talking about what they want to do with their degree, and so this is a high-powered place. So people are gunning, NIH grants and changing practice and just going for it. So Tyler introduces himself, talks about practice and, you know, what he wants to do, what he's interested in. And he says, he finishes it with, and I want to make $1 million. And there was this pregnant pause. And I'm sitting there, I literally put my hands over my mouth. And I'm like, oh my God, like that's not the thing that you say here, right? Because it wasn't the culture.
Right.
And I thought, oh, this is not going to go over very well. And it didn't until people got to know you more. And you know, Tyler went on to a successful career at Nike, and that was groundbreaking for people coming out of that program. So I've never forgotten that. I was I didn't know if like he just didn't know that like that's not the thing you say, or if he just didn't care. And I think it's the latter. Yeah, I learned it was the latter.
Well, part one I didn't know, but even if I did know, I'd probably say it anyway.
No, it was right. It was good.
Yeah, so we do go way back. So as all graduate students, we try to help each other out in projects, and so Andy's, Chris's research was around, at that time, fatigue. And you could model fatigue at different areas of the body, whether it be cortical, whether it be at the sarcolemma, whether it be at the motor end plate. So now we're getting a little geeky. But he would work you so hard that, you either gave up or cried. So that was it. And then he knew. And he didn't believe you either way if you gave up or you cried. And so he would send a pulse, a shock essentially into your nerve to make sure that you were telling the truth.
I had a 1 amp stimulator, which is a lot of juice. And I would have him contract as hard as he could, and then you'd do interpolated twitch. He'd stimulate on top of that, and it was like getting kicked by a horse, I think.
It was,
so,
yeah.
So
I do remember.
Yeah. So I owe you.
So there's another PhD story. So I'd asked one of the exercise science graduate students to help me in my research. So it was a study on the knee, right? So it was patellofemoral pain. And so she was a runner, and so hooked her all up, and she was really great. And then afterwards said, well, you should be a participant for my study. We need some subjects. And so, of course, you say yes when people participate in yours. You want to reciprocate. So I said yes. And then she says, well, there's a test first. And I said, that's fine. And then she hands me this hose. And you're supposed to swallow the hose. So if you can swallow the hose, then you're in. So that was it. Right? And she was really non-committal as far as what this entailed. And so so I get there, and she's interested in, it's a Gatorade-funded study, so she's interested in blood flow in the small intestine. And so you have to fish these instruments down into the small intestine. And it's a good thing it was going south, not north. So, but they fit inside this tube, and so you had to swallow this tube and then fish these instruments into your small intestine. And then they imaged you to make sure it was. So you'd just lay on your side, and you could see the probe, flop over and go around the corners, and then. Well, she was interested in blood flow during exercise. So then you had to exercise at 80% of VO2 max while running on a treadmill, while ingesting various liquids. So Gatorade, sugar water, salt water, regular water. So to this day, I don't think I can drink orange Gatorade because you're throwing up. I mean, it is serious as you're trying to exercise with this tube down you. And the weirdest sensation though was when they got it in the right spot, they would you had a balloon tied to the end, and they'd blow up the balloon,
control. So then the instruments would stay in the right place and not jiggle around. And so, but it was this sensation of immediately being full. So they'd blow it up and it was like, oh, I'm full. It was just this weird sensation.
That's cool.
It was really cool. So this goes to a little snapshot of who I am. I think I'm pretty smart, but I'm not very bright. Because she said I had such good data, she'd like to bring me back, and I said yes.
Really?
Yeah.
You went back another time?
Yeah, and I went back another time. So, but as a poor graduate student, I think I got like $200.
Yeah.
So that's a lot of money as a poor graduate student.
So though it does kind of remind me of how. So for me, I've had muscle plugs taken out of my legs, and we've both done fine wire EMG, and you contract on that too hard and it crimps, and I've got wires
it
still
may not
stuck
come
in
out,
me.
Right? It may not come out.
So I compare that though to like nowadays, there's a lot of PTs who want a PhD.
Yeah.
And a lot of the learning that you do in your graduate training really does take place, it's really outside the classroom.
Yeah.
And these kinds of experiences, if there are models that don't really allow you to do that nowadays, and I'm really concerned about that, and like I'm a movement science guy, and so like I want to know how things work, how we move, and I worry a bit about in DPT programs as curricula get parsed down. That stuff is oftentimes the first thing to go. And are we graduating people who really don't understand movement? They only know anatomy in sort of an anecdotal context
or clinical context.
Right.
That's it.
But they don't really understand human movement.
Yeah.
And I think that's scary.
I think that's fair criticism. I think just like all high schools aren't created equal and universities, so there's a reason why Harvard and Stanford and those stick out. MIT. So I think it's the same with the PhD. I think what happens really is you're finished with PT school and you're starting to have a family, and it's really hard to then commit to a traditional role where you're on site for 4 years, 5 years, and you're plugging away every day. And I get that. And I think it does dilute, kind of the what that PhD is.
Even too at the DPT level.
Yeah.
Our curriculum is laid out for anatomy and biomechanics for 2 semesters.
For a whole year.
For a whole year.
Right.
And a lot of places are cramming it into like the summer
course,
8 weeks, 10 weeks.
Yeah.
And it's like, let's just get it out of the way. Why are we doing that? I don't.
Well, I mean, I guess that was. Well, you helped me create the program. You were here, as a founding member of our program, and so that was intentional for us to think about how do we do. If we're going to start our own, then you worked in many PT programs, and so did some of the other faculty, and so taking learnings from them was important, and understanding that many times that anatomy course in the summer was not helpful for them in the clinical parts of the program because it was way too intense and they just forgot too much.
And I think too I like teaching anatomy as a neuroscience person,
right?
Because it's easy to learn anatomy in a way that impedes your learning later when you're trying to understand like how movement occurs.
Yeah.
I've had the good fortune to work with like totally world-class anatomists, and they don't know anything about movement.
No, I appreciate that you have. I like your background. So neuroscience is your wheelhouse. But then you took a year postdoc in biomechanics, right? So it's one of these things that I think help solidify movement. And I'm just learning because I'm across the hall from you, and we pick you up at the airport a lot, and
Mm-hmm.
those kinds of things. And I do see him a lot. So, picking up these pieces, of neuroscience that even biomechanics, related fields don't know, and so. The motor control and the and the neuroscience pieces of that are really helping us fit with regards to what does the biomechanical data really mean, and applying a bit of that certainly helps.
Mm-hmm.
So why are you why are you interested in neuroscience? What motivated you for that? Because you've learned it a long time. I mean, you've
So
kind of known.
I started off originally when I first went to Iowa when Gary Soderbergh was still there. I mean, I finished my bachelor's degree in PT, and then 3 days later I was in a master's degree, and I thought, honestly, when I finished my bachelor's degree, I thought, if this is what PT is, I will go back to tarring roofs, which is how I paid my way through college.
Yeah, well,
my two best friends in PT school immediately went on to enrolled in medical school.
Oh.
And so I remember talking to a person who I admired a bit, and I asked, what's the best PT program in the country? And he said Iowa, and I thought, okay, that's where I'm going to go next. So I started off with Gary Soderbergh in foot biomechanics, lower extremity, and I just quickly realized that I took a real neuroscience course, and I realized that I had been completely duped in PT school about the neural control of movement, and it made me angry. I'm still feeding off that anger somewhat today. So I realized that I've really got to get a handle. I was just so deficient, and not just deficient. I was taught wrong things. The way how muscle spindles and Golgi tendon organs work, what their role is in movement.
Right.
And we're still 40 plus years out of date in understanding that. So yeah, I mean, I guess I'm neuro, but I'm to really movement is something that emerges from the body. So if you want to understand it, you've got to be willing to follow wherever the thread goes, and it passes through anatomy and biomechanics and psychology and many disciplines. So
that's I like that story a lot, and in some respect, I don't know. Us as a program, we've tried to make sure that we're up to date and current, and bringing in relevant information. And we miss it a bit upon occasion, but for the most part, I think we're on track. There's people out there that they just like to scream, about how angry they are. In PT, and not really offering solutions. And so I think what I like about us is, we try really hard to provide solutions,
Yeah, we're not just...
So like you, I mean, you're just not screaming about how horrible people are, but it's like, no, this is how we think the neuroscience works from a motor control standpoint and an input, and how sensation... I mean, you just go down the line real logically about how we think movement happens and how it's controlled, and even so much as, I love, and maybe we'll get into that, but your comments about the brain is interested in the future. And predicting the movements for what's going to happen next, not the past. And that's just if there's a foundation of neuroscience that we should remember, as movement experts, it's some of those concepts that it's like you said, it's not just anatomy, origin, insertion, action, blood supply, nerve supply, and then move on.
Right. No, there's a thing called the Lindy Effect.
Oh yeah, right. Yeah, tell us about that.
I don't know if you want to get into
that.
that.
No, let's do that. Yeah.
So the Lindy Effect which I think originated Nassim Nicholas Taleb, who's written The Black Swan and Skin in the Game. This is his most recent book.
Yeah.
It's outstanding. It's the idea that the longer that something exists, the more likely it will continue to exist. And it's really true.
Yeah.
It's one of the reasons why thoughts get so entrenched in certain professions, where certain kinds of technology are hard to migrate away from. And it's really true, I think, in several aspects of how we understand human movement.
Yeah.
And the only cure for the Lindy Effect, there's only one cure.
Yeah.
And that's to show that the object or the idea that you're invested in has harm.
Has harm. Yeah.
So harm is the key part. And it's sad to me, like I look in textbooks today, like people do not understand how the nervous system controls movement. And they perpetuate these ideas that make it hard to move on from things like PNF and NDT.
Yeah.
And, I'm not wagging my finger at
Sure.
those approaches.
Yeah.
But you really have to take a serious critique at what those things were founded on.
Yeah.
And in the 1950s, when that was the state of the art for how we understood things, it made sense.
Right.
But when you look at the work of people like Anders Lundberg,
Right.
late 50s into the 60s, and his the people he trained, Elżbieta Jankowska, Hans Holtborn. I mean, these are real like giants in the neuroscience of movement.
Yeah.
Been publishing steadily since the 70s, and things don't change though. You look in textbooks and you still see Golgi tendon organs are there for protection, and muscle spindles sense stretch. I mean, neither of those is true.
Right.
They're not true.
Right.
So if you cling to that, then like it's sad to me that someone would invest years in like getting certified in PNF.
Right.
To then wake up and like, are you really going to be open to thinking about whether that stretch biases the spindle?
Or movement pattern is,
Yeah, you move in diagonals.
that you move in these ways.
Yeah, or that we have key points of control that that regulate movement.
But don't you think some of that is, I think I mentioned this in an earlier podcast, our profession is really young, compared to medicine, engineering, some of these other professions. And so I think that might be some of it. Just because, by the time we have a theory, and then we try to figure out if that's true. But I do agree with you on the Lindy Effect, though. We're not throwing things out, and it's you see that in medicine, that the Lindy Effect does not hold very often because they're really interested in what is harmful, and they do cut it off immediately.
But see, that's I don't think it's youth. I think it's a problem in our profession where we don't think about, like, we think just doing something is better than doing nothing.
Yeah.
And we don't bother to ask, is there any harm that we're doing? Now, it's not going to be harm in the sense that you may have a malpractice suit filed against you.
Right.
But is it harm when you waste a certain period of rehabilitation where you didn't maximize the time for the patient? I would call that harm.
Yeah, I think I would agree with you, especially in stroke rehab or these places where, there is a finite time that you can maximize the, the brain's ability to regenerate. Yeah.
So, like an example of harm.
Yeah.
ARPAN, 2017, Journal of Neurophysiology has an article looking at gait in people with multiple sclerosis compared to people who don't have MS.
Yep.
And so you get the typical sort of analysis where, there's balance issues and things like that. But what they also did is they did a neurophysiology segment along with it. And they asked the question, how does sensory processing differ between people as they walk with MS versus people as they walk who don't have MS? And what you find is that people with MS do not downregulate incoming sensory information the way that you and I do when we walk.
Yeah.
They don't downregulate it. Okay, so there's an impairment in people with MS where their nervous system is maintaining a certain priority for incoming sensory information that you and I don't have.
Right.
So think of like the therapist who may work with someone with MS, and they are going to do, what do we do with people? Right? You sit on a stool and you brushing and tapping. We're going to facilitate this muscle at some point in the gait cycle. Okay, like you're actually making the problem worse because you're providing an abnormal increase in input.
Right.
So you are doing harm.
Yeah.
I'm thinking too of Jeannie Yang and Dick Stein did a paper in the 90s, 1990. There's something called a reflex reversal, where and they just followed up on a lot of animal work that had done before them. So if you stimulate sural nerve, it's a sensory-only nerve.
Yep.
Yeah, in the back of the leg. So when you stimulate it, it's only sensory. It's not motor.
Right.
So they stimulated the nerve at different points during the gait cycle.
Sure.
And what you see is that the sum of all the inputs coming from muscles, joint angles, all of that regulates how sensory input is processed
taken into
at the spinal cord level.
Yeah.
So when you stimulate at some phases of the gait cycle, the same sensory input to the same spot causes an excitation in tibialis anterior, and at some phases it causes an inhibition.
Right.
So it's the sum of all the inputs. That's what Anders Lundberg was getting at.
Right.
Okay. So when you do this brushing and tapping on folks, you literally have no freaking idea that input is going to cause a chance for increased muscle activity or a reduction in it.
Yeah.
Like that should give you pause about you putting hands on people in that way while they walk.
And we will do a MythBuster session in the future with you and
Am I doing
Jeff.
too much myth busting?
No.
Okay.
I'm just because I think we want to get into that, in a standalone podcast. So I like this because I don't know that it's inconsistent with even other parts, not just neuroscience. Let's pick biomechanics. So in the late 90s, as an example, some of the engineering literature and engineers thought of the gastroc as it's been thought of as a spring years before in the 70s even. But they looked at models, the behavior of the gastroc soleus and then the tendon, and it is in the late 90s hypothesized that the purpose of the gastroc tendon or the Achilles tendon is to store energy. Well, that didn't really emerge until just recently. So in maybe the last 5 years or so, they're attaching diagnostic ultrasound to the calf. They're doing tendon modeling, so you can actually look at the length change in the fascicle versus the length change in the tendon, and come to find out, they're absolutely right. If you combine that with EMG, EMG is electrically silent at push-off. So that's weird. And why is that? Well, in the gait cycle, the behavior of that muscle tendon unit is to store energy up until push-off, and then as you push off, that energy then is released from the gastroc. So there's very little actually muscle, sarcomere, tendon movement. Cross bridge movement. It's
So it's an isometric.
mostly isometric.
Yeah.
Very little shortening happens, and that's and we're going to get into that with, I think we're going to have another podcast with expert in running as well, and try to get into these kind of the details of that. But I guess that's a long story, but not just in neuroscience, I guess. And so I guess that's why I said that maybe it's because we're young, that some of these just haven't emerged yet as far as how does the body really work. I remember at Iowa, Dr. Darling's class, muscle physiology class, skeletal muscle biology. Fascinating to go over the models of the different models of the Hill model, all those things that you learned about how the muscle works, and actually seeing sarcomeres move in a petri dish when acetylcholine was added, right? So just really very basic science stuff on understanding movement, and but even that's outdated. So I guess just the more that we know, it seems like just the more that we change the models and understand how movement works.
Yeah.
Yeah.
Yeah. Just to add like another layer of complexity here, you've been talking
That's
about
good.
Movement.
Yeah. Right.
Movement. It's not a foundation of neurologic PT, and I think at least I see in my orthopedic friends.
Yeah.
Right. Orthopedic people think neuroscience is the sexy thing. Right. So they want to tie some neural. If you could put neuro something in it, right? It sounds really mysterious. And
it's an X-ray into the nervous system.
Yeah.
Right. Yeah.
The force. So I'm not being critical. I'm just saying that's where we're at,
no,
right?
Yeah, that is true.
But here's the thing: is we often in PT try to manipulate sensation to get a certain kind of motor output.
Yeah.
And what I would challenge is that because of Lundberg's work, right? It's not very predictable.
Right.
When you sum all the sensory inputs up, what you're going to get in terms of motor output.
Yeah.
Now, there's better models. We could talk about that another day. But we have to let people indwell in their own sensory experience and move through it, because it's not just sensation modulates movement.
Yeah.
It's movement modulates sensation.
Right.
So I'm thinking of George Carvel at Pitt. He's a PhD PT, but a classically trained neuroscientist.
Right.
And when was it? 2008. He came out with a paper that it was in Nature Neuroscience, and it was the front page cover, of Nature Neuroscience. And people spend their whole life in neuroscience studying the sensory processing coming through rat whiskers.
Right.
Literally for decades, neuroscientist graduate students have spent their whole career studying these pathways, so it's very well mapped out.
Right.
And Carvel asked a very interesting question, right? There's a muscle at the base of that vibrissae.
Yep.
And he asked, when that muscle's active, how does that change the way that sensation flows through these different parts of the nervous system?
I know where you're going to go. This is fascinating.
And it completely changes
it. Does,
it.
100%. So once movement happens...
Movement changes everything.
Right.
So if you are trying to brush and tap somebody while they're moving, the movement itself is changing
really,
things.
Yeah.
Now, do you want to be providing input, massive input, like to the skin, through the whole gait cycle,
right,
when you have no idea how? I don't think you want to engage that. I think you want to come back and do things like set up an environment that forces an individual to maybe move in a certain way or just give some spotted cues, right? Just here and there, some small cues.
Yeah.
But movement changes sensation.
Right.
That, like, I don't think as a profession we've really thought deeply about what that means.
No,
and it's true for pain too.
Well, that's exactly where I was going to go. So when you put your little, he's got a, for those that don't know, he's got a diagram of the Lundberg model as well as the Sherrington model on his front, on his office door. And so, we've been serious about pain here. We changed a course, and it's now a chronic pain course. And Dan is primarily the instructor there. And so what helped me and really in chronic pain is understanding that Lundberg model, because now all of a sudden everything is, and now it's more complex, because now you got all this stuff that we talked about, GTOs and spindles, and now you got pain fibers, C fibers, alpha, all of those going into an alpha motor neuron, and then also movement. And so now all of a sudden, no wonder the brain's confused in some of these chronic pain situations, because when I move a certain way, I'm feeling pain, and it's not coming from damage to the muscle or the damage to the skin or the nerve. It's not coming from the pain fiber. It likely could be coming from movement. Yeah.
Yeah, and then you get into the perceptual element.
Yeah.
As well.
Right.
Very few people in movement science think about the massive amount of unconscious sensory input that your cerebellum is processing for you. A very large. This is an amazing thing of what physical therapists do. I always do with the first year students when they first get here during orientation. I'll lift my arm, right? And I'll say, okay, what's the first muscle activated, right?
And you're standing.
I'm standing, right? So. And they'll eke out anterior deltoid, and they're like proud of themselves. That's good, okay.
I bet our producer JD knows the answer.
Yeah, JD. So the correct answer when you go to lift your arm out in clinnohumeral flexion, the first thing to active is going to be plantar muscles in your feet, and then your gastroc-soleus group.
Right.
Because those anticipatory responses are, I know you know this, but
no, this is great.
Yeah,
I know.
Those muscles are checking your center of mass that's going to shift when you go to lift your arm up. So we have this whole level of movement that is below our conscious level of experience. Right. That even entry-level PT students who have a good bit of knowledge already coming in about movement, don't know. Right. And so this is a bold thing that PTs say that we're going to do. We're going to go in and we're going to take people who now have a lesion, who truly did not know how they were doing what they were doing in terms of movement. And now we're going to get that person better. Right. And it's not enough to just make the person consciously aware of it. I know when I first started practicing, I sort of had this idea while you're walking in mid-stance and gait and you're hyperextending the knee, you just gotta try to maybe activate quadriceps more.
Yeah, keep the knee flexed a little bit more.
Right. Activate quadriceps. And you think if I just point this out, they'll fix it. But then, if you try to imitate somebody else's gait, it's a hard thing to do.
Right. And
that's because, and actually there's a great paper that came out a couple of years ago. I'm going to have to look it up. It was a great summary article about how much gait doesn't really rely much on cortical drive.
Oh, right.
It's subcortical, and it's taken. The decisions are made at the spinal cord level. At the spinal cord level.
Right.
So like you, through central pattern generation and these other things, how do PTs tap into getting somebody to do something again that they didn't even know how they did it before?
Right. Well, okay. So I'm going to throw biomechanics in. Now all of it's storage in the tendon. So you have no idea consciously about all of that. So all the complexities that you just talked about the nervous system regulating, now it's actually maybe regulating stiffness. It's regulating these things that we have no idea consciously or even at the spinal cord,
Yeah.
what's happening.
Right. Well, your cerebellum probably knows, but
Okay,
you're not
right.
you're not consciously
Right, not consciously.
you're not
Cerebellum.
consciously aware of it. So how do you tap into
Right.
the unconscious element of movement? And I don't care how good of a yoga master you are, you're not wired to tap into that.
Right, you're wired actually to make it to make it more efficient.
Yeah.
So let's hold it into the spinal cord as much as we can.
So in vision,
Yeah.
right? It's well known in visual processing that you have multiple streams that sensory information is processed. So you're probably familiar with cortical blindness.
Yes.
So it's the idea that the stream that is consciously available to you is knocked out, but the stream of vision that is not consciously available to you is still intact. So you take someone with cortical blindness and you have them walk down a hallway with obstacles, and they will tell you, I can't see anything, but they can walk and miss the obstacles.
Right. They can even catch a ball.
Yeah, it's amazing.
Right.
So what I would say is, like, we have to think about movement in those terms as well. Like,
Yeah.
I want to make a case for the unconscious sensory part of things. And there are certain kinds of movements where increasing your, like, mindfulness is kind of a term I hear tossed around a lot, okay? There are aspects of movement where that may be helpful, but there's other aspects of movement where drawing someone's perceptual awareness towards it is not only not helpful,
Right.
it could be detrimental
Right.
to the execution
Right.
of the movement.
Right. Yeah, I'm with you on that. I think our bodies are designed to maximize that efficiency. So if you think about, we're gonna go back to running. Eliud Kipchoge is a runner, one of the most successful runners. Broke the 2-hour barrier for the marathon, and so it's online. You can see that. And after he's done, he does not look tired. So if you think about physiology of muscle, that's impossible unless you're storing energy in the tendon. Because the work that muscle had to do, contract, if it had to do that for 2 solid hours at a 4:35 pace, which would be a sprint for most people, it just wouldn't happen unless you're storing energy in the tendon.
Yeah.
Yeah. Which is unconscious.
Yeah.
Yeah. Subconscious.
So moving beyond, I don't mean to keep coming back to sensation,
No,
but
go.
Like, we've got to get beyond the whole I'm going to manipulate sensation to change motor
action.
output
Yeah,
a bit,
yeah.
right? What you have to ask yourself, what does the nervous system care about?
I love that question.
In doing this movement.
Yeah.
Okay, and I'd say a lot of times it might be something like center of mass.
Right.
And I know you and I have talked
Yep.
about this
Yeah.
with running. Like,
Yep.
there's some really interesting studies that show that when center of mass starts to deviate,
Right.
within a stride, you are making adjustments to keep that center of mass constrained
Right.
within a certain limit.
That is a better predictor of where you're going to land than your foot.
Right.
Yeah.
And that's why, as much as PTs are and should be experts on muscle,
Yeah.
we've got to also like knowing muscle is only part of understanding movement.
Yeah.
You've got to know the mechanical part, like how it all comes together. So center of mass is an important variable
Yeah.
that you need to have a grasp on, because your nervous system cares about it. And and when I teach anatomy, we don't I don't know, let's take iliopsoas muscle, right? Anatomists all call it a hip flexor.
Yeah.
And it is, okay? But iliopsoas, like, look at the extensive tie-ins it has in the lumbar spine.
Yeah.
Right? And then you think about during the gait cycle how the knee extension you get during swing, a lot of it is initiated by iliopsoas imparting an inertial torque to the knee.
Right.
So your nervous system sees iliopsoas as a knee extensor muscle in a very real way.
Right.
And if you teach PTs right? How, like muscle actions based on just the anatomic crossing.
Right.
You're never going to grasp that.
No, and you're right. So it gets complicated. So as an example, just to go off on that, I love that because in the walking and running cycle, what you see is that opposite hip contributing to the power generation. It's aligned with the ankle. So the left hip at push off as the ankle is it's continuous with push off. So that left hip power is helping the ankle torque and knee in the opposite limb.
In the opposite limb.
In the opposite limb.
Yeah.
Right, because like you said, there's energy being stored in that massive tendon, and it's not just a hip flexion. Right.
You know, I think of and I'm thinking of this because we've just finished dissecting upper extremities.
Yeah.
Flexor digitorum profundus.
Yeah.
Right. People, anatomists will call it a flexor of
the distal.
The DIP
Yeah.
flexor because
Yeah.
it crosses there. Great.
Yeah.
Right. But what else does it cross? Right,
What?
it crosses PIP joint, the MCP joint, the
Yeah.
CMC, right? I mean the wrist.
Oh yeah, all of it.
And so the question is, when you do single joint movement, right? People will
Yeah.
call this a simple joint movement.
Right.
You're generating a flexion torque at the MCP joint
Yep.
and at the wrist.
Yep.
And why is it that you don't get flexion?
Well, you know,
Right?
I do.
I'm just saying.
No, I know.
You have to activate wrist extensor muscles
Right.
to negate the
Torque.
flexion torque
Yeah.
generated at the wrist
Right.
and the MCP joint.
Right.
And you have no conscious idea of how you do that.
At
but
all.
you do it.
At all.
You do it.
Right.
So I love this. You know, when my kids were learning to ride bikes, right? They were a little precocious. I think it was like 5 years old. Right, and they're riding their bikes, and they have no concept of the physics of the bike.
Right.
They have no
Or
concept of
their center of
their
mass
legs.
and-
They have no
right.
concept of any of that. And I could point that out to them, and I probably did. Right?
Probably.
I probably did, like when they're trying to learn,
Right.
and it doesn't help them.
Right.
But you have this. You have this tacit level of knowledge about movement, and that's the level that PTs have to operate
Right.
in a lot
Yeah.
of times.
So let's go back to the GTO and muscle spindle.
Right?
Right. So, so what's a better description of those as far as their function?
Okay, so spindles are not sensors of stretch.
Right.
They're sensors of length and rate of change in length.
Right. So length and rate of change.
Right. And meaning, right, you know, it's not just about lengthening fibers.
Right.
They're sensitive to shortening.
Right.
Golgi tendon
Right.
organs, sensors of tension, but very small amounts of tension.
Right.
1 Newton or less. So
they
they're
can
giving
sense, right.
they're giving feedback in about how good your motor unit recruitment is and what
Right,
you need
right.
to up or down regulate.
Right.
But the key is that you have to look at the two plotted against each other.
Right. That to me was fascinating.
Yeah.
Once we understood, all right, what are the purpose of the GTO and muscle spindle? Because that's what the body cares about.
Yeah.
Because that's what the body's measuring. So that was an epiphany for me just recently. What does the body care about? What is it measuring? It's measuring these certain things.
It combines the two
Yes.
to get a handle on stiffness.
Yes. I'm with you.
That's what it cares
I
about.
got sold on that.
Yeah.
So the body really cares
And-
about joint stiffness.
Right. And you have to I'm trying to think of what it came out in. I'll have to get it to you. Last month there was a nice little short review article that came out about the stretch reflex.
Yeah.
Stretch reflexes don't exist for tendon taps, although I mean they help with that.
Sure.
Right.
Right,
and,
right.
and they are there for some perturbation type stuff.
Right.
Okay. But that circuitry is there to
Right.
to not just send input in about stiffness,
Right.
but
Or make sure the doctor knows that you have a reflex.
Yeah.
That's not the
No,
why
no,
it's
no,
there.
no, no, no. So Haukenreimer, it was in the 1980s.
That's
okay,
right, yep.
Right, Zev Reimer.
Yep.
So if you classic study, so you take a muscle and you stretch it, and you look at how tension changes over time. And now you take the spindle and you cut the spindle, and you go ahead. It's a sensory organ, right? You cut the spindle. So you take now the extrafusal fibers, right, the muscle itself, and you stretch it.
Yeah.
And what you see is that not only is there not an increase in force, but the muscle at the new resting length can't maintain the tension at this new length.
Right.
So it shows you that the spindle's role is to regulate the mechanical properties of muscle.
Right.
It's not just a sense organ. It has a profound effect on the extrafusal fiber's ability to maintain tension.
Right.
So
huge.
It's huge.
Huge.
So that's how we have to change the way we look at it. I can't stand like this idea that you have to stretch a muscle in order to activate the spindle.
Right.
It's a ridiculous idea.
Right.
Right? Because you can up and down regulate the sensitivity of the spindle through gamma drive.
Or well, I was going to say stress. So same kind of thing.
Right.
Where other inputs are causing that spindle to have more or less tension.
Yeah. So by regulating the environment, you can regulate gamma drive.
Right.
And you can have some effect if that's what you want to manipulate on with a patient.
Yeah.
But you don't have to put your hands on people and stretch them while they're moving.
Right.
It's just, it seems ridiculous to me.
Yeah, it does. It does to me too. Yeah. Give us an example of how this could be applied to PT in practice.
So, So first you gotta have some consideration that maybe what you're doing is harmful wasting time. So that's the first thing.
Well,
so the second,
let's keep saying harmful. Because it's payers, it's your insurance company, it's you out of pocket, it's time, it's all of those things. So I'm going to say it's harmful.
Patients make decisions, financial decisions that affect
Yeah.
other parts of their life.
Yes.
And if their kid's not getting the Chromebook that they need because mom's in PT, like that's a harm.
Yeah.
Right. So an alternative, we could have a whole podcast on alternatives, but one approach is to manipulate what are called control parameters, which are it's getting at the question, what is it that is organizing this movement for the nervous system? So take something like speed or weight. I'll use weight as an example. You can manipulate the weight of an extremity. You're not putting your hands on the person. You're letting the person deal with what it means to have
all those inputs in.
All this new input into here. Yeah. And it's not just about adding weight. It could be about taking weight away.
Right.
So in interesting, again, study, Esther Thielen at Indiana.
Yeah.
There's this phase that, as you know, so babies go through this stepping cycle phase where if you suspend them and you put their feet, their met heads on the edge of a table, they'll start this stepping response. And something interesting happens is over the course of a few months, right, the babies, they get those nice, thick thighs with the little rolls, and you want to do the raspberries on them.
Thunder thighs.
Yeah, thunder thighs, right. The stepping,
and the double bicep.
Yeah, the stepping response goes away, and the way PTs often describe that is they say, well, they've lost the primitive reflex.
Right.
Okay. Right, they lost the primitive reflex. And so Esther Thielen is like, we don't, we use reflex circuitry. You can't see it manifesting itself in this situation. What's going on? Like, do you really lose it?
Right.
So she did these studies where she would take kids and put them in water and, or look at them in supine as they kick, right? Motion analysis on them.
Yeah.
Come to find out that when you unweight the limbs, the stepping response appears again.
Right.
So the loss of that response is purely a function of the weight of the limbs in relationship to, bone structure and muscle torque producing capability and all of that. So it's not that the nervous system has lost the reflex.
Right.
And that's why I always say it really is true that reflex circuits are the building blocks for voluntary movement. You got to understand, the nervous system isn't just driving muscle like these strings on a marionette.
Yeah.
Okay. A lot of times in the nervous system, the way things happen is some part of the system is removing inhibition from some other descending pathway, right? We have a lot more than the corticospinal tract.
Right.
You've got the reticulospinal tract, the rubrospinal tract, right? All these others that are driving muscle. Anyway, I've diverged from the clinic a little bit, but my point is
right.
that you can manipulate weight
As an easy example of what to do.
or speed is another popular one.
Right.
Just change the way a person is. A little anecdotal example. I remember when I first started practicing, it was before I knew a lot of this stuff. Had somebody had a stroke, had him on remember Kincoms?
Oh, sure.
Yeah, the $60,000
Isokinetic.
coat rack.
Yeah.
Right? So I thought I was a techie kind of person, so I've got him strapped up onto this, the EMG. In fact, I think Gary Smith from Iowa helped to develop the first one.
Oh.
The talking one.
Oh.
Yeah. Anyway, had him strapped up on this, and this guy had a lot of trouble with hyperextension during mid-stance. And I thought if I isolate knee extension, it will carry over during gait.
Right.
So he's working it, and he's getting all this feedback, and the machine's talking to him, and I'm talking to him. And the fire alarm goes off. And we weren't scheduled to have a fire alarm that day, so I figured this is the real
Might
deal.
be real, yeah.
Yeah. And to that point, I hadn't walked this gentleman fast because I was concerned about his knee hyperextension. So the fire alarm, everyone's clearing the gym out, I unstrap him, and we got to get out of here. And he had to walk at a pace that was not his self-selected space.
Right.
Pace. And I'll be damned, that guy didn't hyperextend a single time walking out of that gym.
Right.
And I'm not saying that's going to happen for everybody.
Right.
But it was a good lesson for me that I could manipulate things like speed, and it can have a real effect.
I've seen it as well here. So just recently over the last couple of years, someone walking with hyperextension and then having them run and it goes away.
Yeah.
Right. So I think that's consistent.
And then what you would do is just
yeah.
work on reducing the speed and trying to maintain.
Right. Yeah. Right. One of the the Pandy's work, we'll go into biomechanics again, and so help me understand. So in any gait speed from walking to running, with the exception of one, which is a 4.5 mile an hour pace, the behavior of the tendon and the muscle's the same. So to me, I guess that's it's not contrary to what we're just talking about, but it just goes to show you that our body is trying to optimize something. So in this case, stiffness.
Mm-hmm.
So that way, you were. So this article I'm referring to, it's about 90% of the change in length is happening in the tendon. 10% of the change in length, 5 to 10 is happening in the muscle, with the exception of this weird pace, 4.5 miles an hour. So I don't know, you're a fast walker from the
East Coast walker.
Yeah, East Coast walker. Even 4.5 miles an hour, there's this transition time, do I walk or do I run? So it's really this odd pace. And in that particular case, it's 50-50. 50% of the change in length is coming from the tendon, 50% of the change in length is coming from the muscle. So to me that's fascinating because it's one time from very slow walking to an 11-minute pace, which is a pretty good pace. It's 5-something a minute mile, so it's a very quick pace. The behavior is very similar, with the exception of just that one odd pace that the body can't figure out.
That's Yeah, that's amazing. I mean, you've got someplace in your nervous system
Yes.
a model
Yes.
for how
Yes.
this musculotendinous unit
Yeah.
is working.
And it's probably baked into the spinal cord.
Probably.
Right, because, yeah.
So, as you know, spinal cord learns,
Right.
right? It's not just a dumb conduit
Right.
for descending pathways
Right.
to do stuff. So,
Right.
one thing that comes to mind as you talk about tendon
Yeah.
is we have to capture in movement, we have to capture the idea. There's something called a Mariologic Fallacy. And
Okay, I know what those. I know what the second
And-
word is, but
yeah,
Mariological.
So Mariology
Yeah.
in philosophy is the
Got it.
study of part-whole relationships.
Okay.
And,
Okay,
and a Mariologic fallacy is when you take a part
Got it.
and you ascribe to that part the properties
Yep.
of what's actually the whole.
Right. Muscle and tendon.
So it's muscle and tendon, right? But it's more than that. It's one of the reasons why, like I'm going to go back to neuroscience.
Yeah. It's your
We're-
podcast.
It's our podcast.
Yes, it is.
In neuroscience, you see Myriologic fallacies all the time,
Okay.
where like consider the mind-body problem.
Yeah.
Right. Some people will say that the mind is separate from the body; it's a non-physical entity. And neuroscientists love to point out, well, that's not the case. There's not a non-physical universe, so the mind is something that emerges from the body. Okay, but those same neuroscientists will substitute mind-body problem for a brain-body problem. And they talk about the brain as if it's this separate
Physical entity,
from the rest
right.
of the body,
Yeah.
right? Like someday we're going to be heads, in future. You haven't seen Futurama?
Uh-huh.
Okay,
Yeah.
right. Like we're going to be heads in jars. Okay, and that's not going to happen. And neuroscience has to get away from that. That is a Mariologic fallacy that the brain is somehow separate from the body. And for movement science people, they need to understand that, right? I am so glad that early on in my career, when I was trying to figure out neuroscience, what I wanted to study with regard to movement, I was initially really interested in transcranial magnetic stimulation.
Oh, sure. Right.
And this was the time I was a graduate student.
I remember.
Right, I wrote the FDA because nobody was doing it, and I wanted to try to get a transcranial stimulator, and you had to get FDA approval, and they were really expensive, and so I abandoned it. And I'm so glad that roadblock came, because I focused more on the spinal cord, and that was a good move, because
Yeah.
there's too much of neuroscience that thinks that if we just study the brain,
Right.
we'll understand movement.
Or pain, or you take a fMRI and then interpret what that means.
So here's the thing. If a lot of people have this idea, right? Maybe Elon Musk. Okay, if you can record from the brain,
Yeah.
right, EEG,
Yep.
that you could understand the intent of somebody as they're trying to move.
Right.
And to me, that is a ridiculous notion if you put it in this context. If you take EMG and you load somebody up with EMG electrodes all over their upper extremity,
Yeah.
can you tell what they're painting?
No. You can tell muscles on and off.
You have no idea how to interpret that EMG on its own unless you know you would have to know the physics of how the segments are all interacting with each other.
Yeah.
And even beyond that, you still wouldn't know how somebody's painting.
Right.
So if you can't record EMG alone and tell me about movement, how are you ever going to go back in the nervous system and record from cortical neurons and be able to make any sense of what's going on in terms of movement?
Yeah.
Now, that doesn't mean that you can't stimulate the cortex and get some thumping of a muscle
Right.
in your hand.
Right. Which has been done.
Oh, sure.
I actually did end up getting a brain stimulator, right? And I was a guinea pig, right?
Right, and there's a use for that. I'm not saying you shouldn't do that.
No, I know you're not.
Like when you want to know how cortical neurons are up or down regulating their excitability,
Right.
it's a great tool to use.
Right.
But you got to be careful, and I say this to my orthopedic colleagues. Okay, changes in the mapping of the brain for muscles or segments.
Yeah.
Like that is not an indicator that your movement treatment, your therapeutic exercise is effective.
Right.
Because there's all kinds of studies. You lop a finger off, right, of a rat, and you do mapping. I mean, you will see within 48 hours, you will see the cortical map change.
Right.
So a change in itself is not much. And I see people doing like gait studies, and they'll do like exercise in gluteal muscles, and then they'll say, okay, these gluteal exercises changed the cortical map.
Right.
And my response to that is, right, of course it does.
Right.
But what does it mean?
What does it mean?
You know, what does it mean? You can cut a finger off and the map will change.
Right.
When you go to bed tonight, your cortical map will be a little bit different than when you got out of bed this morning. So just because you see a plastic change in the nervous system,
it may or may not be meaningful.
It may or may not be meaningful. So don't think that
Don't
your
think
therapeutic
that it always
interventions
is, right.
change. Of course it's going to have a plastic change. Doing nothing will have a plastic change. Do you know what I mean?
Yeah, I do know what you mean. Yeah.
So
That's actually that's a good take home right there. You know, because the mind is plastic, and it's supposed to change.
Again, I'm treading into orthopedic territory, so you stop me.
It's okay. You can't actually have ortho without neuro.
Right.
So you can have neuro without ortho.
No.
Still works.
Yeah. Yeah. No. So. Shit. No, what was I gonna say?
Sorry. You were gonna go, and I'm treading on ortho. I hate to always go back. I hate to always go back to ortho.
I
You're
know.
treading ortho territory.
That's right.
Cortical mapping. Your brain changes.
Yeah, it's cortical mapping, brain changes. We got to pause
No.
here. So cortical mapping, brain changes. God, I was going to make this profound point.
Wasn't going to be. It's going to be profound.
Brain mapping. I was going to say something about orthopedic people. They need to. Oh, I know what it was.
Go.
Okay. Yeah. Okay. So, JOSPT is a great journal.
Yep.
Okay. But what's interesting is like when people try in orthopedics to talk neuro, what they still cling to is that there has to be a structure-function relationship that's hard, that's clear and defined, right? So we were just talking a moment ago about how God, I'm losing my train of thought. Okay, so a little orthopedic commentary.
I know. I'm with you.
Okay. JOSPT.
Yeah.
Right. Great journal.
Yep.
But when people in orthopedics try to come to neuroscience, the baggage that they bring with them
Yeah.
is this structure-function relationship where they always have to try to identify a change in structure that maps to a change in function. And that can be really dangerous in the nervous
Yeah.
system because, like, I think neuroscientists who study movement understand that more that like things emerge.
Right.
And it's true, you get lesions in the CNS and it affects things. But what you don't want to do is, like in orthopedics, if you're really fixed on that back pain always has to have some anatomic correlate that you have to be able to drill down to
Yeah.
get at it, right? I think that's changing in our
It
understanding of
is.
pain.
Yeah, it is.
Right? That it doesn't always have to be this facet joint at this level is what's ultimately causing this pain.
Yeah.
Right?
It doesn't have to be. They're not linking it to a mechanical effect anymore.
Right.
Yeah.
There are things that happen in the nervous system at like second, third order neurons that are deeper in the nervous system where you lose track of the structure, right? And so what you have to focus on is how the function sort of emerges out of that structure. So if you're an orthopedic person that's always got to go to a structural lesion,
Right.
you're gonna don't bring that baggage into neuroscience if you really want to get a grip on what the nervous system is doing.
Yeah.
Does that make sense?
No, it's really great because I think we can go all the way back to the beginning when we talked about Lundberg,
Right.
Where it's so complex that there's just so many inputs that I don't know if we'll ever figure it out. However, because you could modify each one of these inputs and possibly get a change.
Yeah, it's a very nonlinear
Right. Very
input output
very
relationship.
nonlinear. That's right.
Right.
Yeah.
Right.
Yeah.
And that's why I think that the people that are doing work on things like control parameters,
Yeah.
I'm sure this is for a separate podcast, but uncontrolled manifold analysis,
Yeah.
right?
Yeah.
There's a whole area of
That would be interesting to talk about.
we should do that.
Yeah.
There's a whole area in motor control research that looks at movement variability. And there's lots of techniques now that have been out for a while, like uncontrolled manifold analysis, where
Right.
you're basically looking at multiple movements and parsing out what aspects of the movement help you to complete the task. That would be good variability, and what would be bad variability.
Yeah.
It's one of the reasons why, again, I know I'm crossing the line here to orthopedics, but like people who are big on lumbar stabilization exercises.
Yeah.
Right? This idea that you're going to mimic the
Yep.
normal anticipatory, like we talked about it earlier, you're going to mimic the normal anticipatory response to set your trunk
Yep.
before you go to reach for something.
Right.
Right?
Make it strong and
Right. You're going to, it's going to be rigid and
strengthen your core.
strengthen your core, and so you're going to hold your core while you reach. And so hold, reach, hold, reach, hold, reach. Well, the first time the phone rings, right, you're holding the baby and the phone rings, or you're standing there and you see your kid's going to fall, and you go to reach and you don't set your core, bam. Okay, we've got to get away from this idea. Like with postural control, it's really big. You've got a stack of vertebrae in your back for a reason.
Yeah.
And they're there to be able to accept weight, in that we have a very sophisticated way of using our spine, our head, our extremities to regulate our center of mass.
Yeah.
And we want people to have a variety of ways to be able to accomplish that.
Yep.
And as a PT, we need to develop that variety. If you're doing things like lumbar stabilization, you're really robbing of someone of good variability that they can use for movement.
Yeah.
And it's not surprising. I don't know that this is true. This is anecdotal from orthopedic PTs I talk to who end up getting patients who say, and you stop me if I'm wrong, because I know I'm out of bounds, but people who will say, I've been doing what the PT told me, these lumbar stabilization things, and now it's no wonder that they have hip pain and problems in their upper thoracic spine
Right.
and their neck.
Yeah.
So.
Yeah, it's consistent in the literature in back with patients with back pain that you have heightened electromyography. So your muscles are on at a higher level of those with back pain. So now what we're trying to do is turn it on more by having them contract their core and stabilize them as they're trying to lift when their muscles already are more active than they should be anyway. Yeah. So you're right.
It's this assumption that variability in movement is a bad thing.
Right.
And that's not the case.
I'm with you on that. Some of the recent, our own research, it's not published yet, but I think we're working toward it. But We did 100 basketball players, a little more than 100, and 100 volleyball players, and looked at injury rates, and then also looked at some dynamic movements, box jumps, landing, and things like that in the biomechanics lab. Looked at knee stiffness and some of these other parameters that we're interested in the biomechanics. And we stumbled across those that were injured had less variability than those that were not.
Those who were injured have less variability. Yeah.
Yeah. When you looked at the way that they're, we did 3 or 5 trials each, and so there's a particular pattern, a profile of how they land. And those that were injured had a less variability than those that were not.
Yeah.
So I think I'm with you. I think there's something to that.
Yeah. And it's not just for elite athletes.
Right. Because like you said, your body is trying to figure out how to, pick something, control your center of mass. Right. So you're exploring the environment. So trying to constrain it too much doesn't allow you then, now I'm going into neuroscience, right? Doesn't allow you then to explore the environment so your body can set its own model for how you're supposed to behave.
Yep. Yeah, I'm a big fan. Mark Carpenter has done a lot of work in that area, and I'm a big fan of his. The idea that, anecdotally, right? You bring in a ballet dancer into our lab, and you have them close their eyes, and they sway as much as anybody that you get in the lab, and it's really fun to watch because they can control that cone. But it's just they're exploring. Their nervous system's just exploring the environment, and that feedback is probably
helpful.
It's helpful. It's in the
for
same
other movements.
Yeah, in the same way that hands explore the environment, right? I can feel this cup and get information about it. Sway you can also look at as a form of exploring the environment, and not just the environment, but you've talked about tendons a lot today. Right? You're getting a sense, probably at the unconscious level, of what is the state of these tendons. How stiff are they?
Cool. We talked about a lot today, so thank you for coming in. And Dr. Chris P. We call him Dr. Meszaros for short, but appreciate your time. One of the things we're moving, the new building, and we're rebranding, and I think this is perfect because we talked a lot about movement, but we also talked a lot about life. So this idea of being experts in movement and life is important to us. So I think there's lots of take-homes here with regards to just not making it so simple and using our whole degree to provide the best care for people.
No, I think we're trying to train a therapist that can come out and be competent and confident, but also you do want to have a little bit of I don't know that skepticism is the right word. You want to hold your knowledge in a plastic way so that you're receptive to new things that come along, and in that way you're not doing the same thing in 10 years that you did when you graduated.
No, that's great, because I think there's elements of that. We want to challenge the status quo to be sure that we're moving the profession forward.
And to do that, you've got to understand human movement.
Right.
So, thanks for having me.
Cool. Yeah, thank you. Wow. Great topic today. Great conversation today. Thanks for listening. Thanks for tuning in. And just make sure you're connecting with us in some way, whether it would be liking or subscribing. You can connect with us directly, and be sure to visit our website, motifcenter.com. And if you want to be featured in our Q&A, send us a question. We'll be happy to answer that in our Q&A session, and let us know where you're coming from.